do pap smears there, the civil hospital. And I was shocked. I said, you can't do pap smear, like I think it costs about 100, 150 rupees and for the small kit. And he says, no, we don't have the availability. And you know, like this is a cancer that is practically eradicated from the rest of the world. And unfortunately, we are not able to do a simple test. But I think we did that cancer screening camp in our civil hospital a couple of months ago where we were all also involved. And I think they screened like 1,000 women at that time. 1,000.
Interruption is allowed.
Yeah.
So I think all doctors must have a day for pap smears. So I think we can fix a day for the doctors themselves. I think you should all opt for it. Okay.
Yes, definitely. And actually, that brings me to another point. How many of us get it?
Yes, this is what I said. If I say, then only everybody will come. We put a day for that.
Yeah.
And Anupa one day for mammography.
Mammography as well, definitely.
Yeah. One day so that everybody can
Yeah.
see.
Because,
only for the doctors, not for the patients.
They need to come and get it done. So it is, and where we are practicing, it is a leading cause of death in the rural women. And we know that there is a huge rural population around Jalandhar that do come in for treatment over here. And we see a fair number of patients who have this malignancy. The median age is around 48 to 50 years, and that is kind of where they're getting postmenopausal or they're in the perimenopausal range. They sometimes do not understand the importance of the the bleeding that they're getting, because sometimes they just think it's a resorption of this their menstruation, but actually it's postmenopausal bleeding. So again, I think counseling will make a huge difference. So the risk factors are HPV, 16, 18, 31 and 33, and we know we have the vaccination for this. Sexual behavior, having multiple sexual partners, activity at an early age and poor sexual hygiene, STDs, HIV, chlamydia, smoking, multiple pregnancies, which again is very, very common in our areas, low socioeconomic status, family history, and use of DES. So again, all of you already know this. So vaginal bleeding, menstrual bleeding is longer and heavier, bleeding after menopause or increased vaginal discharge, bleeding following intercourse or pelvic exam, and pain during intercourse. Again, staging, I'm sure all of you know much better than I do, because we always go to our gynecologist for the staging. And this is one area where everybody says it doesn't matter what the CT scan says, it doesn't matter what the chest X-ray says, it matters what your gynecologist is telling you, because they're the one who's going to, it's a clinical staging. It has really not much to do with your scans. So the prevention, and this is, I think, the most important. That is what you want to tell your patient, that get your pap smears. Of course, they should have started it a long time ago, after first vaginal intercourse or by the age of 21. The vaccination is not for them, but maybe if you are talking to your postmenopausal, you can encourage them that they get their children or their daughter-in-laws or people around them vaccinated. Women between the ages of 9 and 26. And I have a question for all of you. I don't know which one you are asking your patients to get, the one with the tetravalent one or the bivalent one. I always tell them tetravalent one, right? So that's what we are also.
In case they have to save some money and they don't have money in their pocket, they can go in for the bivalent. Also for the time.
Is there a big difference? Is there a big difference in the cost?
Yes.
I thought it's 2,000, 2,000.
No. But it is best to educate your patient and give them a choice, whatever they want.
So diagnosis again is your cervical cytology, your biopsy, and the treatment is, usually it's not surgery. Surgery is for the really early stages, 1A and 1B and higher usually go for radiation and with the addition of chemotherapy if they are higher stages. And the best thing is that cervical cancer actually has really good survival rates. And I will tell you a scenario, like, we have patients who come in and we diagnose them with cervical cancer and we tell them about getting the treatment. They go back and they get lost because they think that it's cancer, it's not going to get cured. But actually, early stage of cervical cancer, 90% of your patients are going to be saved, and across all stages, of course, provided they're not stage 4, but 70–75% of patients you're going to be saving. So I think that if you have these patients, you really need to encourage them to come and get their treatment. It's not like lung cancer where we're not going to make that much of a difference. Cervical cancer is a place where we really can make a difference in the lives. Because we're talking about gynecological cancers, I thought I would focus on ovarian because this is sometimes lost. We don't talk about ovarian cancer a lot, but it is getting more and more common. And of course, when you're a woman, and the age where it really hits the women is around 60 early 60s is where they are most likely to be diagnosed with this disease. Of course, that is not to say we don't see younger women, but the average incidence is around 63 years of age. And even though it is not the most common gynecological cancer, it is the leading cause of gynecological death, cancer-related gynecological. So 70% of our patients are diagnosed with advanced disease. The overall 5-year survival rate is only 30%. And in India, ovarian cancer constitutes about 5 to 10% of cancers in women. Now, I've actually, one of my very, very close friends' mother, who was a gynecologist, she was diagnosed with ovarian cancer, and the reason that she was diagnosed with it was stage 3C. And it was very sad because she had like very minimal ascites, some mild pain, not too much, and by the time the investigations actually happened, it was quite late. And this is a very, I would say it's a subtle killer, because we really, pelvic pain or a little bit, who doesn't get it? But you need to tell your patients that, you have to come in if you're having these sort of problems, especially, if they are entering that age group around 55 and 60 years. Don't ignore your body. And that's what I tell patients, even those who come for follow-up after treatment. They're like, when should I come in? What should I come for? I said, listen to your body. If something is not normal, you don't feel that your body is functioning the way it should, don't ignore it, because we all have a tendency to say, अच्छा, थोड़ा सा headache है, चला जाएगा, या खांसी है, चला जाएगा. By the time वो चला जाता है, it's already 3 months. So tell the women, listen to your body and come when you don't feel right. Ovarian cancer, we usually have, the pattern of spread is very typical, momental peritoneal deposits, ascites, not so common that it's inside the liver, but deposits around the liver surface or subcapsular, and pleural effusion. I cannot tell you how many patients come in for pleural effusion and we diagnose them with ovarian cancer. So that's actually very, very typical. The risk factors, family history of course is very important. We've all heard about BRCA1 and 2 gene mutation, and I want to actually tell you it's available in India. It's very expensive, it costs 50,000 to get the BRCA test, but a couple of the laboratories, if one index case is tested positive, they'll do the other ones for 1/4 of the price, the rest of the family. So that is something important to know. Nulliparity, having unopposed estrogen can be contributory. Use of fertility drugs and increased intake of saturated fat, meat and animal fat. Symptoms, like we already talked, are very non-specific. There may be some abdominal discomfort, some stomachache, some bloating or fullness. Very occasionally vaginal bleeding. I have to say, I don't see this a lot. I mostly see what we've already, the distension and the discomfort. Sudden weight gain, loss of appetite, and a lot of patients here I've seen with subacute bowel obstruction. They'll come with this, alternating diarrhea, vomiting, alternating diarrhea and constipation, a little bit of vomiting, and that's because they have the metastasis, the cirrhosis metastases along their bowel wall. So the diagnosis is very, very straightforward actually. The CA125 will be elevated. You will do an FNAC, you'll see some, on your ultrasound you'll have some adnexal mass, you'll get an FNAC, it will be adenocarcinoma, the CA125, usually is like in the thousands range. And the treatment is very, it's actually one of the cases where radiation has no role. Most of the patients end up getting chemotherapy and surgery. And again, most of you are gynecologists, you know that we like to get the cytoreductive surgery first, but when I trained, it was mandatory that patient has to see the surgeon first and then they come to the medical oncologist. But here, because most of our patients present with really advanced stage, we end up doing kind of the sandwich treatment where we give a couple of cycles of chemotherapy first, then we go for the cytoreductive surgery, and then we do adjuvant chemotherapy. Now, unfortunately, even if they are not metastatic, stage 3 patients also don't have that long survival. Like most patients will recur within a couple of months, and stage 3C, etc. survival is anywhere between the range of 2 to 4 years. But if you have your early stage cancer, stage 1, some patients do very, very well. You must have a lot of success stories to tell, and we'll be happy to listen to them anytime. Breast cancer, like I talked, I think my last talk was about breast cancer, and it's something that I'm very passionate about because my mother had it, and breast cancer is becoming more and more common in India. This 1 in 22, it's kind of I don't even know if it's true anymore. 1 in 22 is what they used to say a couple of years ago in the newspaper. But in the next couple of years, the Indian government is really making a concerted effort to get proper numbers. And maybe we'll have something better to say than this when the NCRP, the National Cancer Registry Program, is really full-fledged and getting all the data from everywhere. So breast cancer is higher in the urban areas as compared to the rural areas. Of course, the risk factors, we know it's female. The average age is around 54, 55, is majority of our patients fall in this age group. Menstrual history, basically being having a longer period of menstruation, being exposed to those hormones for a longer period of time, early, but yeah, that means early onset and late menopause, having late childbirth or not having any children, obesity, lifestyle and diet, and HRT. Now, hormone replacement therapy, I think you all know better than I really do, but we've heard from the WHI initiative, and I think that gave a lot of conflicting answers. So I'm going to ask you, what do you think about it? Because what the data from, I think they looked at about 51 studies, and the final thing that the experts said was that unopposed estrogen therapy and combined estrogen progesterone therapy will increase your breast cancer risk. And the number that they actually gave was that for every year that you use hormonal replacement therapy, your risk of cancer, of breast cancer, goes up by about 2 to 3%. 2.3 was the number. But I would like to know what you counsel your patients about HRT. So anything that you have faced?
Premature menopause start things can be given up to the age of 50.
But after?
And suppose the patient has attained menopause at 45 or 50, can be up to 60 also. But it's regular follow-up. With the history of the previous, any history in breast cancer in the family,
be very careful, right? And also what is interesting is that when they stop the use of these hormones, the risk starts to go down again. But except in the WHI, they said that having your combined estrogen progesterone, the risk is still there. But that was the only thing that I was not very clear about, because in the WHI, they actually said that unopposed estrogen is not that harmful as the combined combination is. And
as
so,
far as uterus is concerned, we have to give a combination.
Yes. Yes. Now, another interesting thing is that patients who get breast cancer or endometrial cancer while they're on HRT, the cancers are actually lower grade for some reason. So,
but another thing is, in case we give HRT, the colorectal cancer is there.
Yes.
So you are ignorant.
Nothing is ever right, you win some and you lose some.
I think educated patients who
Yeah.
come on a regular follow-up, they can be given.
Yeah. Another question.
Follow-up.
Rather, it should be.
We have to discuss
Yes.
with the patient and have to
Usually it is
educate
1
them.
year, now I say it should be every 3 months to 6 months, you just never know what happens.
And besides that, ma'am, I think it should not be given right and left to everybody. That's what
Yes.
I feel. It should be given to only those patients where it's really
Where it is
indicated.
really needed.
That's, I think, the crux of the.
Very true, because each and every person has to be utilized.
Yes, definitely.
Earlier, like 10 years back, it was being advocated to be given right and left to all menopausal women. And I think we doctors were also advocating. But over a period of time, we have come to know that it should be only given to those patients where this is really indicated. So we need to work on that.
Yes, I think, like you said, individualized therapy is the answer to most things. So symptoms, again, everybody knows the symptoms. You'll have a lump, you'll have lymph nodes enlarged, retracted. The advanced cases, you'll have the fungating mass, or if it's, you'll have the port-orange type of appearance of the breast. You can have supraclavicular and higher cervical lymphadenopathy if it's an advanced stage. And this is again where your postmenopausal patient really needs to get their screening, because although we advocated, again, the guidelines are kind of different everywhere. In US they say after 40, in Europe they say after 50, but then 50 is kind of where everybody agrees that this patient needs to be getting their annual mammographies. They need to see their physician, and this is also what is important. Sometimes patients just go on their own and say, okay, I got my mammography. But no, you need to have your clinical breast exam. That is also very, very important. And of course, we encourage patients to do their breast self-exam. And like I said, if the patient comes in when they're healthy, you can teach them the proper way to do the clinical, to do their self-breast exam, because a lot of patients don't really know. Treatment will be a combination of surgery, radiation, and chemotherapy depending on the stage, and of course hormonal therapy if they are ER positive. So we won't go into that a lot. Head and neck cancer, like I put this in mostly because of the, it's getting more common, and now that we have, we know that it is contributing to to death among women. So head and neck cancer is really, I would say, an amalgam of diseases because it includes various subsites. There will be oral cavity, salivary gland, the paranasal sinuses, the pharynx and the larynx. And it is a fallacy to think that this is only a cancer of men because, as we've seen, it's no longer true. The risk factors are smoking, alcohol, chewing tobacco, HPV and EBV infection, exposure to chemicals, exposure to wood dust and sun. Some really alarming pictures, but unfortunately we do see patients like this. And what are the symptoms? What should you counsel your patient about? A lump or a sore that does not heal, a sore throat that does not go away, change in the voice or hoarseness of the voice, difficulty in swallowing. Sometimes even that patch in the mouth that has been persistent for a long period of time. Older women, they'll say their dentures may not be fitting properly because there is a growth, unusual bleeding or pain in the mouth, chronic sinus infection. We have seen patients, who have this draining sinus from the lymph node that keeps getting treated as TB, and it finally turns out to be malignancy. Nose bleeding if they have a nasopharyngeal mass, and frequent headaches. So treatment we really won't go into, but again, chemotherapy has a very little role in this disease. It's mostly surgery and radiation therapy that are of prime importance. But of course, if it's an advanced stage, then we have combination chemoradiation therapy or just chemotherapy if it's metastatic. Gastrointestinal cancers. We are seeing more women with esophageal cancers, and I'm talking more from what I've seen in the last couple of years, and I see a lot of women with gallbladder cancers. And that is again a cancer that kind of slips beneath everybody. The patient gets the cholecystectomy, for some reason the path is lost, and then finally they come back and they have liver metastases or ascites, and it's very painful, and there's not a lot, unfortunately, that we can do for these patients. So gastrointestinal cancers again is a lot of subsites: esophageal, gastric, colon, rectal, hepatobiliary or pancreas, gallbladder, liver, and cancers of the anal canal. And there's a lot of these cancers have really poor prognosis. I think cancer pancreas is one of the solid tumors that has the worst prognosis, among the worst prognosis, I should say. Even hepatocellular cancers, it's hepatocellular cancer is something that is again, the patient has some hepatitis B or some sort of cirrhosis, they complain of bloating, etc. The liver is enlarged, and suddenly they have these masses in them. And there's not much that we can do about hepatocellular cancer. Like, I have to counsel patients that whether you take the medicine or you don't, the difference is only 1 or 2 months. So, how important is it to take the medicine? I don't know.